Okay, great.
All right, so just going to make sure that you can move your slides forward. As we talked about in your training, I will be doing the first. I will be moving forward the first slide, and then 1 second, and then you're going to start on the slide of acknowledgement of commercial support. And so when I'm moving the slide forward, I'm going to be assuming control over the mouse. So all you have to do when you want to move forward to your presentation is just move your mouse and then click on your left and right arrow keys in your keyboard. And if you remember from our training also, you can kind of tell whether or not you have control by going to the attendees box, clicking on staff, and then you'll see that your mouse will be highlighted in black when you have control. That's just a little tip. Okay. All right, so it looks like
I'm moving the mouse.
Mm-hmm. And then you can either click to move forward or use your left and right arrow keys to move forward.
I'm trying right now and it's not, oh, is it just, okay, there we go, great.
Yes, and there's going to be a little bit of lag in the slide deck, like what we talked about. So just kind of a tip is to always have, the copy of the slide deck with you, just so you can keep on moving through the presentation, even if there is a little bit of lag.
Right, I have that right here.
Awesome. Good. All right, so we don't have any during the question and answer section. I can't remember. Did we decide whether or not you wanted to have Jessica read the questions for you, or did you want to select the questions yourself?
I think I was going to select them myself.
Okay.
Just so that and do you remember, I can pick ones that seem most relevant.
Yes. And do you remember how to do that?
I click on the plus sign to expand the questions, and I should be able to see them there, along with the asker.
Yes, ma'am. Yeah, that's perfect. And then for Q&A, depending on how long we have, well, depending on when the presentation ends, maybe we can end Q&A around 1:57, and that'll give Jessica time to put a statement.
Okay, great. I'll keep that in mind for the timing. Okay.
Great.
Awesome.
So I'm going to turn it over to Jessica, who's just going to sort of run you through some of the verbal cues, so you know when to start.
Okay, great.
Hi, Dr. Simmons. So as the moderator for the webinar, I just provide a brief introduction about how participants receive their continuing education credits, the emails that they can expect to receive, and then at the end of my introduction, I'll actually introduce you. So is it okay with you if I read your bio to you right now to make sure that it's correct?
Sure.
Okay, great. So I'll start off by saying, at this time, I would like to introduce Dr. Martha Simmons, today's presenter. Dr. Simmons is a family doctor who practices full-spectrum family medicine with a focus in women's health and family planning at a federally qualified health center in Harlem, New York. She completed her residency training at the University of Pennsylvania and subsequently moved to New York for a position as a women's health and advocacy fellow with the Reproductive Health Access Project. After completion of this one-year fellowship, she joined the faculty at the Harlem Residency in Family Medicine, which is affiliated with Mount Sinai. Dr. Simmons' full bio is available on ARHP's webinar web pages. We're thrilled to have her with us today, and I'll hand it over to her. Dr. Simmons, you have the floor, and then you'll be free to start the presentation.
Great. It said something like I needed to press *1 so that everybody could hear me. Does that happen automatically, or should we need to press that?
No, don't press that because that'll start the broadcast. So I'll be responsible for starting us out.
Okay, great.
All right.
Did the bio sound okay?
The bio sounds perfect.
Great. All right. So do you have any last-minute questions for us?
No, I think I got it.
All right. Sounds good. So at about 1 o'clock, Jessica will start us off just by saying, we'll give it a minute or two to let people sign in, and then we'll start the presentation at around 1:02.
Okay, perfect. Oh, I do have a
Alright,
question.
so-
How's this audio sound? Is my audio sounding okay?
Yes, it sounds perfect.
Okay, great.
All right, thank you so much. And we'll just go on to mute until around 1 o'clock.
Perfect. Thanks so much.
All right.
I'm going to eat
Thank
some
you.
sandwich.
Enjoy that.
Thanks.
The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone, and thank you for joining today's webinar so promptly. We'll give folks a couple more minutes to join us and get started at 1:02. Thank you for joining us for today's webinar, Risk Made Real, Communicating Contraceptive Risk. My name is Jessica Monmany, and I'm the Senior Education Associate at ARHP. I'll be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the links provided to you in the reminder email or via the webinar's chat box. You can also use this box to enter questions throughout the webinar, which will be answered by our presenter at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure that we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Martha Simmons, today's presenter. Dr. Simmons is a family doctor who practices full-spectrum family medicine with a focus in women's health and family planning at a federally qualified health center in Harlem, New York. She completed her residency training at the University of Pennsylvania and subsequently moved to New York for a position as a Women's Health and Advocacy Fellow with the Reproductive Health Access Project. After completion of this one-year fellowship, she joined the faculty at the Harlem Residency in Family Medicine, which is affiliated with Mount Sinai. Dr. Simmons' full bio is available on ARHP's webinar web pages. We're thrilled to have her with us today, and I will hand it over to her. Dr. Simmons, you have the floor.
Thank you so much, Jessica. I'm so excited to be talking to you all today and to be working with the ARHP. This session is brought to you via a grant from Merck. And these are our disclosures. So this content that you're going to hear today was created by a committee. Of our committee, Dr. Piper does have research support from various pharmaceutical companies listed there. The rest of us have nothing to disclose. Okay, so what are we going to talk about today? So by the end of this activity, I want all of you to be able to identify the factors that affect how our patients perceive and misperceive risk, and also how they use that to think about contraception and pregnancy. To be able to define some basic terminology, including absolute risk, attributable risk, relative risk, and odds ratio. And additionally, to discuss some specific risks associated with pregnancy. And hopefully, what we really want you to take away from this is to get some effective communication strategies, including demonstrations and graphics that you can use within your counseling framework for your patients so that you can help facilitate really patient-centered counseling that's effective. So let's start off by defining risk. And why is this important? So it's important to communicate effectively about contraceptive risks and benefits because of the approximately 6 million pregnancies that occur in the United States each year, about half are unintended. Of these unintended pregnancies, only 5% of them are true contraceptive method failures. So what that means is that 95% of patients who experience unintended pregnancy each year are either not using any type of contraception, or they're using contraceptives inconsistently and ineffectively. And although there can be other barriers to our patients using contraception, misperception about risk can be one of the things that prevents women from using their contraceptives as recommended. Of course, other barriers, including ones that we as providers put in place, requiring pelvic exams, asking for Sunday start, which delays our patients starting, not having good appointments, or not giving 12 refills at a time, and then also other systems saying patients not stopping because of spotting, turning on a period, and not understanding the risks and the package insert. So there's a lot that goes into there, but one of the things is definitely risk perception. So let's define risk. So risk is defined as a danger or a hazard, and also the probability of suffering harm. And that harm can include both significant risk events and side effects. And some side effects can be perceived as a significant risk by our patients. Of course, some side effects, such as amenorrhea, can be considered as positive and don't increase risk. So to get a sense of the probability of suffering harm, we use certain risk calculations. So some common risk calculations that we want you to understand are absolute risk, relative risk, and odds ratios. We're going to define these and also illustrate their use in communicating risk to patients. So absolute risk. So absolute risk is the same as incidence. It provides the rate of occurrence of a condition or disease in a population group that's exposed to a specific hazard, infection, trauma, or event. So in other words, it's the risk of an individual faces of a given outcome. It doesn't talk about relative change in risk. If you have a low absolute risk, that means it's unlikely that you'll experience the given event. Conversely, a high absolute risk means that you're more likely to experience that event, or you are likely. So we calculate this by summing the total number of events divided by the total number of people at risk over the exposure time. When we're talking about contraception, we'll often talk about pregnancy risk. And so that's the total number of women who experience pregnancy given a specific contraceptive method divided by the total number of women in the population who could become pregnant. And we often do that over the course of 1 year and express contraceptive efficacy as in women years. So that's absolute risk. Let's move on to relative risk. So relative risk is the probability of an event in one group divided by the probability of the event in another group. It reflects the relative likelihood of developing an outcome. Importantly, relative risk must be calculated using incidence rates. So that means we need a prospective study design, and we need to know what the baseline incidence of a given outcome is in a group. So when we're interpreting relative risk that exceeds 1 is an increased likelihood. When we're talking about risk or a poor outcome, that would be favoring harm. Relative risk values that are less than 1, as seen here, are interpreted as decreasing the risk or favoring protection. These bars shown here are your confidence intervals. And if your confidence interval crosses 1, that's a null result. And these are the 95% confidence intervals, which indicate that there's a certainty of 95% that the probability will be within these two values. So if your 95% confidence interval crosses 1, then that is a neutral or a null result. If we want to reduce the size of the confidence interval so decrease the size of these bars, often a larger sample size for the study will help us with that. Okay, so moving on to odds ratio. So odds ratio is very similar to relative risk. It's the ratio of the odds of event in one group divided by the odds in another group. However, we don't need to know the underlying incidence. So for example, for case control studies where we don't know the underlying incidence in the group, we can use an odds ratio instead of relative risk. So for studies where we don't know kind of the baseline prevalence, we can use an odds ratio instead of relative risk. So for example, case control studies, you'll see them using the odds ratio calculation. So how do we interpret odds? So odds are expressed in the terms of percentage likelihood that an event will happen. So for example, if you're saying that a horse has a 25% chance of winning the race, the odds are 3-to-1 against winning. We could also express that as a 75% chance of losing and a 25% chance of winning. So to extrapolate a little bit further, when the odds are 9-to-1 against a horse at a racetrack, that means that the horse has a 10% chance or a 1 in 10 chance of winning the race and a 9 in 10 chance of losing the race. Now, examining only relative risk or odds ratio is dangerous. This can be really misleading. Both can suggest a more significant increase or decrease in risk compared with the presentation of absolute risk. And what that means is that if the absolute risk of an outcome in a population is very low, even if your relative risk or your odds ratio shows a doubling, that's still very rare. And so that can be hard to grasp without making sure to put these statistics in the context of the absolute risk. So many factors can affect an individual's perception of risks, and that can specifically with contraceptive, and that can include individual factors. So, with just the person and their understanding of contraception and their life experiences. If lack of understanding of statistics, because some of these things are complicated. So if you don't really understand statistics, this can be hard to really perceive risk. Framing, which we're going to define in a little bit further along. The media. And then also psychological, cultural, historical, and social factors. And then the provider brings something to the table too and can influence risk perception. So if the provider is unsure about the optimal way to present risk information, including how much information to present, what order to present the information in, and how to use tables and graphics, then that can make this unclear and can change how your patients end up perceiving risk. There are definitely other factors that affect contraceptive risk perception. There can be stigma related to contraception, right? As providers, we often talk about having a healthy diet and exercise or being really, really good for you. But using condoms and using contraception to prevent pregnancy is also important. And so I try to do a lot of destigmatizing when I'm talking to my patients about sex, of course my consenting adult patients. I say sex is a normal, healthy part of life. I want you to be able to enjoy this, as long as you're, feel safe with your partner and it's your choice. And I want you to be able to enjoy it safely. And so that's why I recommend, birth control and condoms so that you can safely enjoy this normal part of life. And then, of course, there's a lot of historical background that comes into this. So a lot of our patients may remember the Dalkon Shield IUD, which was in the 80s, which had a lot of poor outcomes. The string actually whipped bacteria up into the uterus, and so there was a lot of infections and some serious complications associated with that, which caused it to be withdrawn from the market. So your patient might be thinking about that IUD when you're talking about current IUDs, which are very different. They have a differently designed string, so they don't actually increase your risk of infection at all. But, the patients may have that old IUD in the back of their heads. And then, of course, there's some of the history of our country where we haven't always been great to our non-white populations. There's histories of forced sterilization, there's eugenics, and then we also have to think about how we, just all of this reproductive coercion history. And I feel this a lot because I practice in Harlem, so I have a lot of patients who are from Puerto Rico where there was sterilization of women without full consent. I also have a lot of patients who are African American who remember Tuskegee, and people really don't easily trust sometimes. And then we also have some evidence that a personal history of trauma can affect this. So if a patient has been sexually abused, for example, they may be less open to getting an IUD or to having a pelvic exam at all. So let's talk about how we communicate risk with our counseling. So these are some communication best practices. So what makes for effective communication about contraceptives? So the published literature shows that there's two different main types of communication. There's your relational communication and your task-oriented communication, and that you really need both of these, and for both of these to be strong to have effective communication. So your relational communication is all that we do to build a trust and respect and a relationship with your patient. And then your task-oriented communication is making sure you know your facts, making sure that you're confident about side effects and things like that, that you're evidence-based, that you're using visual aids and tools, and avoiding abstract concepts, and that your office or your practice setting doesn't have a lot of barriers to the patient getting and changing contraception if it doesn't work for them. So this slide lists some suggestions for communication with patients about the risks associated with combined hormonal contraception. Now, these suggestions are not evidence-based, but we do feel that these are some best practices. So as a provider, we hope that you will understand risk and how to communicate it, establish an environment that is conducive to conversation, and that you've built a relationship of trust. And this can be especially true among our African American or Latina focus groups in that population specifically have found that many women have had negative experiences with reproductive health or just health professionals in the past, and that's affecting how they view their future relationships with physicians. And a lot of this is related to poor communication. And you want to be able to put the risk into context for your patient. So, I often say that life has inherited risks, and that all of the birth control that we have is less risky than pregnancy. So all of the risks that we often associate with combined hormonal contraception, death, stroke, VTE, are much more likely with pregnancy itself. And that for most women, the absolute risk of a serious adverse event with hormonal contraceptives is very small. And then, of course, remembering that cultural, literacy, social, and developmental issues definitely affect how people are going to perceive your counseling. And then, of course, I think this is something that might hold some of us back from discussing risk. But remember that discussing risk may make it come to the top of somebody's mind and could lead to increased perception of risk unless you're very careful to put it into context. When you're providing information about risk, you can also discuss how patients can reduce their risk. So you can overall, if a patient's worried about heart attack and birth control pills, you can tell them about the statistics, but then you can also talk about ways that they can reduce that risk. So, quitting smoking, exercising, all of that good things that we should be telling our patients anyway. We should also remember to present absolute risk, not just relative risk or odds ratios, which, as we talked about before, can be misleading when given on their own. And you can use different forms of numerical data to explain risk, as well as verbal and visual formats. And presenting things in multiple ways can make sure that you're reaching most people in their best learning method. You want to be aware of framing. We're going to talk about that a little bit more in a minute. And use your risk comparisons with care. So you can use risk comparisons, but be careful and make sure that they're applicable to your patient and make sense. So framing. So framing refers to how we communicate the information and how we mentally arrange it. So basically, framing is colloquially, is the glass half full or half empty? Are we talking about a chance of survival or a chance of death? And we do have studies that show that when something is positively framed, so you talk about the survival with cancer with this treatment is 2 and 3, patients are more likely to opt for that treatment versus if we say the chances of dying with this treatment is 1 in 3. Now, comparative risk. So this table, I really like it for a few different reasons. It helps us put in perspective the risk of death associated with oral contraceptives. And down here at the bottom, We have automobile driving for your reference. And so the chance of death with driving an automobile, which many of us, I'm lucky enough, I live in Manhattan. I don't drive very frequently, but many of us do this every day. So there's a 20 per 1,000 chance of dying with driving a car in 1 year. And to put that into context here, so here's pregnancy above 20 weeks. And your risk of dying with pregnancy above 20 weeks is 14.5 per 100,000 over 1 year. And we can compare that to the use of contraceptives, of oral contraceptives, for non-smokers aged 35 to 44, which gives you a chance of dying in 3 per 100,000 in 1 year. So there is a risk there, but it's much lower than pregnancy and much lower than the risk that many of our patients are taking every day by driving a car. So the Choice Project, which is out of St. Louis, basically removed barriers for adolescents to getting contraception. So they offered adolescents no-cost contraception and provided education about LARC, or long-acting reversible contraception. And they also did really good counseling with active listening. So when patients were counseled in this method, the majority of the teenagers ended up choosing long-acting reversible contraception, 72%, and only about 28% chose other methods. So when they did that, when they really removed the barriers to getting this care, they were able to reduce the risk of pregnancy. So here is the risk of pregnancy in the U.S. For all teens, which is 57.4 per 1,000. And then if we look at the teens who are having sex, those teens have a risk of 159 per 1,000. And with the Choice Project, with LARC and counseling, they were able to reduce the risk of pregnancy to 34 per 1,000. So it's a very substantial change. And so what you can actually take away from this is that LARC and Depo were much more effective. It was 20 times, the teens that used the pill, patch, and the ring had a 20 times higher chance of pregnancy. And so that's really significant. So not only if we remove the barriers to LARC, does it work very well, it can even work very well in specifically a teenage population. And so this is one way if you wanted to talk to your patients about effectiveness, you could cite this statistic and say that you have a 20 times higher chance of getting pregnant on one of these more user-dependent methods, the pill, the patch, or the ring, versus if you choose Depo, an IUD, or an implant. So that's one way to present your information. So here are some tips to improve understanding of numerical data by your patients. You can try different ways to explain the data, and also try to avoid vague statements about risk without providing any numbers. So for example, you'd want to say both frequency statements and probabilities. So you could say 3 of every 10 women develop nausea using this drug, and that means you have a 30% chance of developing nausea. We also recommend that you avoid shifting your denominators in proportion. A proportion, you want to try to keep your you want to change your numerator and keep your denominator of 1,000 or 100,000. Keep your denominators the same, because many people think that 1 in 400 is more than 1 in 200 if they're not familiar with statistics or if they're not thinking about it deeply. So instead of saying headache developed in 1 of every 333 women, you would say headache developed in 3 of every 1,000 women. And that is a more clear way to present that. Oops. Sorry, I'm trying to advance to the next slide, and it's just taking a minute here. But we also recommend that you use absolute risk instead of or in addition to relative risk. So instead of telling a patient that their birth control increases the risk of heart attack 2.5-fold, it's much more clear to say that heart attacks occur in about 4.2 of every 1 million women on combined oral contraceptives, and 1.7 of every 1 million non-users. So there's an increase in risk, but it's still a very small risk to begin with and to end with, even if you double it. It's also really great to use hands-on tools. So if you have models available in your office, you can leave them in an exam room for patients to explore on your own, or you can bring them around with you. I think this is especially true for the implants and the IUDs. And also the NuvaRing is a really great one to make sure you have a hands-on tool for. You can also assist your patients in locating evidence-based information for them to own, and that can help streamline your counseling. So for example, if your patient comes in and you know they're here for a contraceptive visit, you could have them start off by reviewing some information and give them some time to do that, see another patient, and then come back. And they'll have already thought about it a little bit, which can be great. So the ARHP offers this online interactive tool called Method Match. And so you can launch this in your exam room for your patient, and they can use this to compare different methods, and it also provides basic information on each method. And that's available at the website down here. There are other tools. So as we mentioned in my bio, I did my fellowship working with the Reproductive Health Access Project. And that's an organization that it's a nonprofit. It trains and offers support to clinicians with the goal of making abortion, contraception, and miscarriage care more widely available. And on their website, which is right here, www.reproductiveaccess.org, there's a lot of really great patient handouts on all different types of contraception. There's also one really great one that just has a short blurb about the most common types and is listed in frequency of efficacy. And they're all at a 3rd grade reading level, and they're also available in multiple languages. So I'll find myself using these fact sheets very frequently. I can print them out and give it to the patient. I can go and do something else really quickly and come back and see if they've read about anything that sounds good to them. Bedsider is also another really great tool. It's a private nonprofit, the National Campaign to Prevent Teen and Unplanned Pregnancy, and the site is specifically geared for patients aged 18 to 29, and talks about different contraception options. And it's very visual. There's lots of things to click on. There's videos of people talking about the different types of birth control, so it can be really good for people who interact a lot with technology. And that's available at www.bedsider.org. That is listed right here. And then also a tool for you as a provider to use are the U.S. medical eligibility criteria and the U.S. select practice recommendations. And these are available on the CDC's website at www.cdc.gov. There was just an update a few months ago, so there's some new guidelines. And this is great because you can go and you can either go to the website or even download the app for your device, and it will tell you, you can say, okay, my patient has high blood pressure. What type of contraception is safe for her to use? And you can find out that information so that you can offer the best counseling. So let's change gears a little bit and talk about how to communicate with your patients about the media. So as we know, and we talked earlier, our patients are getting media in lots of ways. So they're watching TV, they're seeing commercials from lawyers, they're using the internet. So there's a lot of different messages coming from all sides. And so when we're talking with patients about this, it's really important to, first of all, acknowledge the patient's concern, and then talk about what report they saw and talk about the gaps. So, you know, if somebody was seeing a commercial about, you know, click here to sue for your IUD, you want to talk about, you know, the stakeholders in that. So, you know, that's put forward by a lawyer. Their number one goal is to make money, or, you know, that you saw that on the news and it's a really flashy headline and they wanted people to watch. So talking about that, and then so mentioning the stakeholders, and then talking about the gaps, talking about what else wasn't in that information that they received. You can then direct the patient to an evidence-based, reliable source of information, such as the ones we discussed, also ACOG, and again, the ARHP website can be really helpful. And you can even put links to these credible sources on your practice website, because the patients are coming to your website because they trust you. And if there's links to direct, reliable sources of information there, it can be really helpful. And so once you've sort of directed somebody to reliable information, then you can talk about it a little bit more and see what they feel about contraceptives after that. So when communicating about risk, it's helpful to show a simple to compare relevant risks. So this graphic emphasizes the fact that pregnancy itself is associated with risk. And this slide shows the risk associated with pregnancy, venous thromboembolism, or VTE, in the United States. So pregnancy and VTE. So we have pregnancy here, and this is a really easy, simple way to see that pregnancy is a much higher risk of VTE compared to high-dose and low-dose OCs, and also the general population. So that can be a really simple way for patients to understand things using a simple graph such as this. Sorry, I went one too far. There we go. So this is a paling palette, and this is a graphical comparison that can be really helpful when you're attempting to explain complicated risk concepts. So with this figure, we can compare the absolute chance or risk of pregnancy among lots of different things. This particular slide is showing the absolute risk of chance of pregnancy among women using emergency contraception. So in green here, we have women who would become pregnant if they used no method of emergency contraception, and we can compare that to our most effective forms of emergency contraception, the Paragard IUD, Ella, and Plan B. And then here in yellow is the Yexi method, which is the older method of taking a certain number of your birth control pills. So as you can see, this is a really easy visual way, and just at a quick glance, you can understand what this is trying to bring across. So a graphic like that one can be really useful to you. So let's talk about counseling strategies. So two strategies or models that work together well, that are complementary, are shared decision-making and the tiered-based counseling model. So these are some basic principles to help you communicate effectively. You want to know your purpose, and your purpose is to help your patients reach the decision that is best for them. And really remembering that is important. You also want to present your information in several ways, including verbal, numeric, and graphic presentations. You want to be an active listener, so you want to demonstrate interest through both your body language and what you say to the patient. You want to try to eliminate distractions as much as possible. I laughed a little bit when I said that, because I think for so many of us who work in busy office settings, this is hard, but doing whatever you can to show the patient that you're really there with them. And then you can also ensure understanding by using methods such as teach back, when you have the patient repeat to you what you just told them. So these are some examples of ways to be an active listener. So what I'll often do is I'll be talking to the patient, I'll say, okay, so what is most important to you in a birth control or a contraceptive? And then you wait and you listen. You ask your clarifying questions, such as, oh, so how are your periods? Or, oh, well, do you know when you want to be pregnant? And then after that, you help them sum up. So you say, what I'm hearing you say is this. And so, for example, I might, use a strategy and then say, okay, so what I'm hearing you say is that you don't want to get pregnant right now, but you're thinking that you may want to get pregnant within the next year, and that you would like a method that's easy for you to start and stop on your own so that you don't have to come back to the doctor when you do decide to become pregnant. Is that right? And so that can really help you save time by doing this in the beginning rather than listing all the methods and then having to do some of this. That can really help you save time and be more effective. This is just talking more about that teach back method that I mentioned. So you ask your patient or client questions to verify that they process the essential information that you gave them. So these are some examples of questions you may want to ask about their contraceptive methods. If I'm working with a teen or a younger person, that make it kind of, well, air quotes, fun, and say, pop quiz, when are you going to start the birth control? Okay, what are you going to do if you miss a pill? And that sort of thing, and do it that way. And shared decision-making refers to the collaborative process that allows patients and providers to make healthcare decisions together. You want to take into account the best clinical evidence available, but also the patient's goals, values, and preferences. And this is really a great model for doing a lot of different healthcare. Because for any health decision, there's not going to be one right. There's not going to be one right answer most of the time. And even if there is, if it doesn't work well for your patient, they're not going to do it. They're not going to be interested in that. So you really want to be patient-centered and allow for self-determination by doing this. It does take some additional time at the outset for the first few visits when you're doing this, but it definitely can save you time in the future and increase compliance. So when you're doing shared decision making, there's 3 basic steps. You want to introduce the options and make sure that the patient knows that reasonable options are available. You want to describe the different options and give detailed information, and you can do that verbally via your tools that we talked about before, method match or patient handouts. And then you want to provide decision-making support. So support the patient while they consider their preferences and decide on an option. And it's good to know that it's important to realize that some people embrace shared decision-making more than others. So some patients are going to say, I don't know, what would you choose? They might ask for a personal option. They might say, whatever you say, doc. And so for patients who say that, I might go back to kind of the questioning part and ask about what's important to them, because they're not really asking what you would choose. They're asking, what would you choose if you were me? So it's really important to do shared decision-making with that question-making process of finding out really what's most important in the active listening. So we were talking about shared decision-making. Now we're changing gears to the tiered-based counseling model. So this provides a visual comparison of effectiveness that gives you perspective. However, it can be too directive, because for some of our patients, effectiveness is not going to be the most important thing, right? They're going to care more about something they can start and stop on their own, or the side effect profile. You shouldn't use this model to push LARC. You need to incorporate talking about effectiveness into your counseling, but be aware that it might not be the most important thing. And that's also, if you've heard about LARC First, which is the American Academy of Pediatrics, and also other organizations have put out this suggestion to counsel with LARC first because it's most effective. I think that's fine, and we should try to help people have more LARC, but I think that we want to acknowledge that contraception is really about patient choice and being really open-minded. Because, and also acknowledging that many of our patients have pregnancy ambivalence. So they may want to be pregnant. They might not want to actively prevent pregnancy. They might be okay with using a less effective method. And if they got pregnant, that would either be okay, it'd be an okay time for them to have a child. They're, feel like that's something that they could handle, or they feel that abortion is an appropriate backup for them. And so if somebody who, if I'm counseling somebody and they're specifically choosing a less effective method, I'll explore how they'd feel about pregnancy a little bit more. And they'd say, okay, so, using the withdrawal method is fine if you feel like that's going to work best for you, but it does work a little bit less well. It does work significantly less well than these other methods that we talked about. What would you do if you did become pregnant? And they'll either say, oh, that would be okay, I definitely could become pregnant right now, or they'd say, oh, that's okay, I would have an abortion. But if somebody says, oh, I couldn't become pregnant, that's a really horrible thing for my life right now, and I really don't want to have an abortion, or you're living and practicing in a state where abortion can be harder to access, then you might want to explore effectiveness a little bit more for that patient. And of course, for all of our patients, we want to make sure that we're talking about infections, providing the counseling. One person who I worked with most recently, her line is, what type of birth control would you like with your condom? We can identify abstinence as being the most effective. We can talk about the other benefits of certain birth controls, so such as for combined hormonal methods, reducing acne, reducing PMS, things like that. And specifically for our adolescent patients, we might be providing contraception to them, and we should support them speaking with their parents about that and being disclosing that they're on birth control if they feel like that's safe for them to do. but never forcing anyone to. And then, of course, if somebody is not interested in contraception or has opted for a less effective method, knowing that they'd be okay with pregnancy, they're feeling kind of ambivalent about it, you can educate about, use that as a great opportunity for your preconception counseling. You can prescribe prenatal vitamins. You can educate about teratogens, make sure they're not in any medicines that would be teratogenic. And if you don't for that, or your practice setting isn't conducive to that, you could schedule a separate visit for it at that time. And I'll often even do like immune titers and things like that so that I can vaccinate patients if they're not immune to measles, mumps, and rubella or varicella. Okay, so let's take everything that we've talked about and apply it to a real-life patient. So this is our case presentation. This is Jess. She's a 30-year-old G2P2. She's a healthy non-smoker, and she has had a hormonal IUD in place for 2 years. So those are the progesterone-only IUDs, the levonorgestrel. The brand names in this country are Mirena, Loletta, and Skyla, as well as the new IUD, Kalina. So she has one of those. She's generally happy with the method. She has regular lighter periods and no side effects that bother her. And she's coming in for her annual Wellman visit. And she lets me know that she wants to have her IUD removed because she's concerned about the risk of cancer with hormones. So you very astutely probe that a little bit further, and you ask her, what is causing you to be concerned about that? And she said her cousin was diagnosed with endometrial cancer at the age of 40. So how do we counsel Jess about having her IUD removed? What's her risk of cancer? So first of all, do we have information that on risks of cancer and either reduction or increased risk with combined hormonal contraceptives and IUDs? The answer is yes, we do have this. We have good data that the risk of endometrial cancer is reduced with COCs. And it's also dose dependent in that the reduction is greater with longer duration of use. It continues for at least 10 years after stopping COCs. We also have evidence that we reduce the risk with IUDs as well. So this is one of the first studies to show reduction in the risk of endometrial cancer among combined hormonal contraceptive users. This study evaluated women with cancer for their use of COCs, and it was a case control study. And so they found that in the study, 17 of the 110 women with endometrial cancer were users of hormonal contraception versus 76 of 249 of the controls without endometrial cancer were hormonal contraceptive users. So when they calculated this out, the odds ratio is 0.5, suggesting a risk reduction of 50%. And we have other studies that also show this. Now, specifically with the IUD, a meta-analysis that included 10 studies calculated a pooled adjusted odds ratio of 0.54. So how you can explain that to patients is that a woman with an IUD had a risk of endometrial cancer that was 46% lower than that of women without an IUD. And this included both copper and hormonal IUDs. And so the proposed mechanisms are an inflammatory response that eliminates hyperplastic shells, more complete shedding of the endometrium. And so there is a plausible biological mechanism for this as well. So that's endometrial cancer. What about other types of cancers? What about ovarian cancer? So studies have demonstrated that oral contraceptive users have a substantially reduced incidence of ovarian cancer. An increased duration of use is associated with greater risk of reduction. So again, it's dose dependent. And similar to endometrial cancer, the risk of ovarian cancer is reduced by about 50% with OC combined oral contraceptive use, meaning that combined oral contraceptive users have a risk of ovarian cancer that's about 50% less than that of non-users. However, remember we talked about we can get into trouble if we're just talking about our risk reduction and not speaking about our absolute risk. So in this study of more than 103,000 women in Norway and Sweden, aged 30 to 49, only 214 developed ovarian cancer over the course of a 10-year study. So the absolute risk of ovarian cancer for women in the study was 0.002, 0.2% or 2 per 1,000. So you want to present the context that ovarian cancer is rare to put that into the benefit of the 50% risk reduction. Right? So because 50% risk reduction on its own sounds great, but it's still a rare risk. A rare risk to start out with, and it's reduced, but still rare. What about breast cancer? So a pooled analysis of 54 studies demonstrated a higher rate of diagnosed breast cancer among combined hormonal contraceptive users than non-users. However, at 10 years after stopping, the rate was similar between the two groups. In current users, the relative risk was about 1.24, meaning that users had a risk of breast cancer that was 24% higher than non-users. However, it's important to note that the cancers diagnosed in the combined hormonal contraceptive user group tended to be at an earlier stage than those diagnosed among non-users. And that might just be because women who are on birth control are coming in for regular checkups and are more likely to do their other health maintenance tests, or it could be for other reasons. And there's also some studies that have not found this association. A study that included a slightly older age group, age 35 to 64, found no significant increased risk of breast cancer among women who are current or past users of combined oral contraceptives. So this might be related to different factors, and it might be the estrogen dose and the formulation that's effective here. So this is from a study published in 2014 that reviewed the pharmacy records at a health system for more than 1,102 women aged 20 to 49. And they showed that recent OC use was associated with an increased risk of breast cancer with an odds ratio of 1.5 compared with past or never users. However, because it was the study was looking at pharmacy records, they were able to see the specific formulation that women were using. And as you can see, the low-dose estrogen pills that most of us are prescribing as our default have a relative risk of 1, meaning there was no difference. It was really the, so it's likely that the formulation plays an important role here. You can see high-dose estrogen pills, triphasic pills, and pills containing ethanodiol diacetate. So really, if somebody's really worried about breast cancer, there is some evidence that there's not a significantly increased, that there's not an increased risk if you're doing a low-dose estrogen pill. So in counseling Jess, we're first going to ask her some open-ended questions to clarify her goals for family planning. So does she want to become pregnant within the next year? And she says no, she doesn't. And then you want to find out if she's otherwise satisfied with her IUD. So how's the bleeding? How's it working out for her otherwise? And she says she loves it. She would not be asking to switch if she wasn't so worried about cancer. You're also going to want to talk to her about her cancer risk factors, some of which might be modifiable, so such as smoking, and some of which are not modifiable, such as the age that she went through and started getting periods, so menarche. You also want to find about polycystic ovarian syndrome, which can increase your risk of endometrial cancer, and her family history. And then you want to find out if she's up to date on her pap smears, because although pap smears aren't the cancer that she's worried about, maybe cancer's on her mind, and we can use this as an opportunity to do our recommended health maintenance. And then remember, biannual exams are listed here, but they're not actually recommended for cancer screening. So we asked Jess, so we present the information that we just went through together, and we asked Jess to repeat back what she understands about the risk of endometrial cancer and IUDs. And she says, and she's able to accurately tell us that the IUD can reduce her risk of endometrial cancer by about 50%. And you ask if she has any other questions or concerns, and then you're going to want to engage in a shared decision-making process. And I find that when you're talking about, when somebody's presenting for and asking for LARC removal, we want to be really careful not to make somebody feel trapped. And this is especially true for non-white patients, given the history of contraceptive abuses and forced sterilization in this country that we talked a little bit about earlier. So once I do all this counseling, and if a patient has decided to keep their device, I always end my visit with, I'm so glad you've decided to keep your IUD. I hope it continues to work well for you. However, if you think more about what we discussed and you decide that you want it removed anyway, please come back. I'm happy to remove this for you. So we tell Jess that, and she says, you know what, I have a better understanding of the risk, and I want to keep my IUD. Great. So that's the end of the slides that we have. So we can move on to the question portion, and please submit your questions in the question box on the control panel. Okay, so it looks like I'm just taking a look at the questions that we have already, and I have from Jamila. Can you talk about how you have counseled a patient on the risk of pregnancy versus the risk of contraception, and how did the conversation go? Great question, and this is definitely something that I do all of the time, and I may have answered this a little bit as we went along, but often how that works is I either might do it when I'm talking about effectiveness, when in the beginning, if I'm saying what's important for you, you know, when are you thinking you want to be pregnant, what would it mean for your life to get pregnant right now. So I often do it there, and then I also do it after they've made their decision. So for example, if I have a patient that's not desiring any contraception, that would be a good time that I would talk about it. And I might say, and I might ask why, and so if they say I'm concerned about this risk of, I'm concerned about the risk of blood clots, I'm concerned about the risk of weight gain, I might say, you know, that's, I totally understand, but that risk is definitely higher with pregnancy. I might use one of those graphs that we talked about. And then another phrase that I find myself saying a lot is, because, and it definitely works well for my unique situation, my clinic also offers first trimester abortion. So often tell patients, okay, great, I understand that after talking you don't want any birth control today, but we do perform abortions here if that's something you ever need. And then the patient will generally have a reaction to that. And most of the time it's actually positive. They'll say, okay, great, thanks for letting me know. Sometimes they'll say, oh no, I could never have an abortion. And then I could talk a little bit more about their risks and say, okay, well, you've chosen a birth control, you've chosen to not have birth control today, or you've chosen to have a birth control that's less effective. So you are at increased risk of pregnancy. And do you want to talk about some of the options we went over earlier that were a little bit more effective? And usually I find that that goes really well. And so I have from Alan, what are your thoughts on the belief that the tier-based model of counseling is coercive? So I think the tier-based modeling can be a really good way to show patients the information, but I do believe that if we only use the tier-based counseling and only counsel on effectiveness, that is when you become coercive. So when you're only talking about effectiveness and you're not taking into account all of the other things that are important to your patient, such as a side effect profile, future fertility, things like that, that's when we reach the point of coercion. So I use the chart that I hand out to patients to talk about effectiveness. The options are listed in order of effectiveness, but I make sure to do that patient-centered active listening where I find out what's also more important to them as well. But I do believe just talking about efficacy is very effective. Oh, great, and another great question. These are all great questions from Rhonda. I know there's a big push for the use of LARC in adolescents. How young is too young for a LARC method? That's a great question, and I think that if somebody is young and sexually active, there isn't a cutoff of how young is too young for LARC. Really, if somebody is having periods and is sexually active, then they can get LARC. Now, there's things that you can do to make your long-acting reversible contraceptive methods more palatable to your younger patients. So you can, if you're worried about insertion, you can have a support person in the room to help them. You can make sure that they've eaten something beforehand so that they have a lower chance of vageling. I always play music during my IUD insertions. I find that that's really great. I give ibuprofen beforehand. and then and a heating pack on the tummy. So some of that is kind of verbicaine, so the music, talking to the patient, and the heating pack. And I find that with that I can really successfully do these, do implants and IUDs in younger patients. So what do you say when a young person says that depo makes them fat is another question. Great, so really good question. So I think there is good evidence that Depo-Provera causes weight gain for some people, and it's the only form of contraception that we have really good evidence that's true, although there is some evidence out there sort of in development that the implant also causes some weight gain. So if weight gain is super important to my patient, then I will make sure to be upfront with them that Depo might not be the best choice for them. How I specifically talk about the weight gain with Depo is I say, you know what, you're totally right. Some people gain weight with Depo. Not everyone does, though. And the people who gain weight with Depo, it's not that it causes you to gain weight, it's that there's some evidence that it might cause you to be more hungry. So if you are more hungry with Depo and you're eating unhealthy food or a lot of snacks, then you are going to gain weight. But if you're more hungry with the Depo and you're eating fruits, vegetables, salads, all the healthy things that we recommend eating, then you're going to be less likely to gain weight. So definitely some of that is in your hands. And so I provide that counseling, and many of my patients won't want Depo for that reason. Many of my patients are already obese, and there are other really good options that don't cause weight gain. So I'll then kind of switch gears to that. And that's part of your shared decision-making process, right? Depo works really well, but if somebody's really worried about gaining weight, they're not going to come back and get their shots every 3 months. Okay. So another question here, if there's discomfort due to spotting, do I remove an IUD stat or counsel, from Dr. AV? So great question. So if there is discomfort or spotting from an IUD, there are definitely things that you can do to help with that so that the patients don't wind up having the IUD removed. So within the first 3 months of IUD placement, it can be really normal to have cramping or irregular bleeding. So I always let my patients know that actually before they get the IUD placed, so that there is some evidence that if patients are provided with full counseling about the side effect possibilities before starting the method, they're going to be more tolerant of irregular bleeding. So I make sure to counsel about that up front. And then if a patient's coming back for that issue, I'll first do a pelvic exam to make sure that I can see the strength that the IUD seems to be in place. If there's a significant amount of, and as long as the IUD is in place on my exam, then oral contraceptive for 2 to 3 months can help. And also NSAID, so taking ibuprofen around the clock for a few weeks can also help. So that's where I'll start. Now, of course, if a patient doesn't want any of those and just wants her IUD out, then I will, of course, in my being patient-centered, remove the device. Okay, and I think we'll do one more, and then I think we're going to be out of time. So how do you counsel patients who are repeatedly visiting the clinic for emergency birth control, such as Plan B? Yeah, I think that's really great, and emergency contraceptive visits are a great time to engage people in discussing regular contraception. So if somebody is doing that, I might say, you know what, I'm so glad, first of all, acknowledging that they're doing the right thing by coming to see you. So I'm so glad that you're coming in for emergency contraception. It seems like preventing pregnancy is important to you. Is that right? And they'll say, they'll answer, and then you might say, okay, are you interested in taking another type of birth control that can help you prevent pregnancy so that you don't have to come in for pills like the Plan B? And they might say yes or no, and if they say no, I might say, okay, explore that a little bit more. So why is that? Find out what they've used in the past. Some people, use one form of birth control, it didn't work for them, and they didn't really get full counseling on other options. That's something I see a lot. So really starting that dialogue and using open-ended counseling is a great opportunity for that. Now, in terms of safety itself, it is certainly safe to repeatedly use emergency contraception. There is no evidence of harm with that, with emergency contraception, either with Plan B or Ella, ulipristal acetate. Okay, great, and I think we're out of time.
Thank you, Dr. Simmons, for that excellent presentation and engaging Q&A session. Before we wrap up, I just want to summarize today's webinar by making sure that all of our attendees feel that they have been able to or that they're now able to identify factors affecting patients' perceptions and misperceptions about risks and benefits of contraceptive use in pregnancy. We also hope that you're able to discuss perceptions of significant risk events and side effects, and also to define absolute risk, attributable risk, relative risk, and an odds ratio. The final 3 learning objectives that we hope you all feel more comfortable with are to discuss the specific risks associated with pregnancy, to identify effective communication strategies within a larger counseling framework, and to demonstrate effective communication strategies and tools to communicate risk. Before we end today's webinar, I just have a few additional reminders. Please be sure to join us for the next webinar in this series on October 12th. Registration is now available on ARHP.org, where you will also find a recording of today's webinar within the next week. As an additional reminder, you will receive an email from Caitlin Forthwith in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. And be sure to print the certificate before closing the internet browser. If you have questions, just feel free to email us at education@arhp.org. Thank you all again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.